Immunotherapy is an alternate treatment for cancer, and while many think it is a recent development, it actually dates back pretty far. And while the history does include a lot of vaccination history, it really is what helped researchers to better understand the immune system and have the opportunity to explore treating cancer with your own immune system, just as vaccinations do. And the history I'll go over in the next couple of slides, but just to give a bit of an overview, immunotherapy uses your own immune system to identify and destroy invading cancer cells. So the goal of immunotherapy is to help modify the immune system in ways that enable it to work better and hopefully destroy cancer before it can situate and become a major problem. And really the great new thing about immunotherapy is the fact that previous traditional treatments like radiation, chemotherapy, and surgery have a potential for recurrence because you are really going in and taking out those bad cells. There is that possibility of missing some and it leading to recurrence. However, with immunotherapy, since your immune system is taught how to recognize cancer cells and destroy them, the potential for recurrence is obsolete because your body is able to continue destroying those cells with its memory. As you can see in this slide, there is a lot of different moments in the history of immunotherapy that have been incredibly important to where we are today. And just to give a bit of an overview, starting in 1891 with Bradley Coley, he was considered the father of immunotherapy because he developed something called Coley's toxins, in which he observed that in a number of cases, cancer patients actually went into spontaneous remission after developing a certain streptococcal skin infection. So he himself actually made a mixture of killed bacteria, those Coley's toxins, and he thought that if he could inject those, that he would be able to use the immune system just shown in that spontaneous remission. He was never really successful in creating a trial and proving his theory. However, in 1908, Ehrlich confirmed his theory by doing actually the trials that he should have done. And then, as you can see, there's a lot more dates in the 1900s that pretty much, to summarize, they continuously found out more about the immune system and were able to see that different parts of your immune system, different cells, had the ability to attack cancer cells. And so that's where we see today there's a couple different types of immunotherapy based on the kind of cells of your immune system that are being used. And I'm not going to go over each one just because really the point was to show that over time, each couple of years, it seems that researchers found a new cell in your immune system and then saw that it could have the potential to kill different types of cancers. And then in this slide, I just wanted to include more of the recent history in the 2000s, just to highlight some of the more recent advancements. And just as the previous slide, a lot of the new developments just came from understanding the immune system better. But we can see that in 2011 and 2010, there were actually U.S. FDA approved treatments for immunotherapy for melanoma, which today is really the biggest thing that we've seen immunotherapy have a major effect in, because it was one of the first things that they found were able to be treated with immunotherapy. So melanoma is one of the main things that we saw in the early 2000s being FDA approved. And then later in the 2000s, we've seen more and more types of cancers being able to be identified and cured with immunotherapies. And to highlight what I was saying in some of the previous slides about the different types of immunotherapy, really today there's 5 main types, and I'll just give a bit of a brief overview. So the checkpoint inhibitors, so they found that the T cells in your immune system that are able to turn on and off the ability to kill cancer cells, the immunotherapy was able to use those checkpoint inhibitors. So instead of them turning off, they could continue to kill cancer cells. so that immunotherapy allowed for it to continue killing the cells instead of your body telling it to stop. And that mechanism is to protect your healthy cells, but again, it does not help to eliminate the cancer. So by using checkpoint inhibitors, you are able to eliminate all of the cancer, and your body does not stop you from killing. And right now, we've seen that this is being used for bladder, cervical, esophageal, head and neck, kidney cancer, non-small cell lung cancer, melanoma, and mesothelioma. And we've also seen they've done some trials recently with breast cancer, specifically the triple negative breast cancer and hepatocellular carcinoma, which is specific to your liver. And then next we have the adoptive cell therapy, which again uses those T cells, but it just improves your immune system's ability to destroy cancer cells by taking them out of your body, growing them in a lab, and once they've gotten to the size that they're wanting for them to be able to kill all the cells, they put them back into the body, and then they're able to better control cancer. And there's two different types. So there's the CAR T-cell therapy, which we see very often in trials today, and that just helps to ensure that your T cells aren't fooled by cancer. Cancer is very easily disguised. That's one of the trickiest parts of it. So that CAR T-cell therapy ensures that your body is able to recognize cancer cells even if they try to disguise themselves. And then the other type are the tumor infiltrating lymphocyte therapy. And that, again, will take out your TIL cells, those cells that are able to kill cancer, and it will grow them again and then put them back in, and it disrupts the signals, suppressing your immune system, as we talked about before. So it just allows your immune system to work at its full capacity. And this one is not yet FDA approved. It's currently being researched for melanoma, cervical squamous cell carcinoma, and bile duct cancer, but it is not currently FDA approved. However, that CAR T-cell therapy does treat blood cancers, leukemia, lymphoma, and it's currently investigating breast and brain cancer. So that adoptive cell therapy is definitely being trialed and tested right now so that it can include a bunch more cancer types. And then the next one is the monoclonal antibody therapy. And this is similar to the last one, but instead of your cells being taken out and grown in a lab, they actually use lab-made antibodies and put those in your body, which can become their own attack force. And those are FDA approved for more than 60 different antibodies. And it treats a wide range of cancers currently. And then we have the cancer vaccines, which help your immune system identify antigens in cancerous cells, similar to a regular vaccine for anything like hepatitis or meningococcal. It's just putting the dead cells into your body so your immune system is able to recognize them. And it is currently approved for prostate cancer cells, FDA approved. And then last one is the immune system modulators. And with the immunomodulators, those include a couple of different cells within your immune system, and each of them really just kind of help to boost your immune system again and ensure that your body does create the proper immune response, as well as slowing cancer cell growth. And some of them actually really keep your cancerous cells from developing its own blood vessels. So that's a major part in stopping them from creating their own lifeline in your body. So those are the current therapies being used, and in the future slides we will go over which are currently FDA approved. So just an overview, I included the current FDA approved immunotherapies and the different pharmaceutical companies that are sponsoring them, as well as the cancers that are currently being treated. I think this gives a good overview to show that there's a wide range of pharmaceutical companies currently working on cancer therapies, and some of the major companies like Merck, Bristol Myers. And then on the red text, you can see the different cancers that are being treated. And of course, it does not include every single one, but it is pretty amazing to see how many cancers are currently FDA approved to be treated already with immunotherapy. And so the impact of immunotherapy, this quote definitely does not encompass all of the impact, but I just thought it was a great little highlight. It pretty much just says that before immunotherapy, only 5% of people with advanced melanoma survived for 5 years or longer, and now with immunotherapy, it's about 50% or more of people who survive 5 years or longer, which is a remarkable change. And that kind of was just to me a way to show with a treatment that has been tested and tested, and now we have different vaccines and treatments for melanoma, that the impact is pretty amazing. And so hopefully in the future we'll be able to do the same for all types of cancer and see that reduction in risk factors. And again, I think, as I talked on earlier, it's so important to focus on immunotherapy now because it really helps to stop that reoccurrence and stopping people from coming back and back and back to the hospital for the same things and getting the same kind of traditional treatments like chemo and radiation that really attack your body as a whole, and you don't feel like you can function as much. Hopefully with immunotherapy we can eliminate coming in and again for the same cancer cells that continue to pop up. This immunotherapy will help to really create long-term remission so that your body can just attack those cancer cells whenever they do pop up. And while the impact has been incredible, there are a good bit of barriers and challenges for organizations trying to create these immunotherapy drugs. So the first one, the major one, is that efficacy is very unpredictable. So it's very, very hard to predict if an immunotherapy is going to work on someone, mostly because there is just so many variations within cancer. So one person could have the same cancer as someone else, however, it's in a different spot in the body, and that could create a different immune response. Or different kinds of cancer can create immune responses, the stage, how long you've had it, if you've had previous treatments. So it is very difficult to know if a treatment is going to work, and of course you want to try it out with the hopes that it will, but going through these processes and the money and time, if it's not going to work, that can definitely be a major detriment. And so there's a lot of ways that efficacy can be more predicted. However, it will take a lot of time and money. So really the major ways that we can eliminate this unpredictability is first starting with identifying additional biomarkers so that we are able to really identify targeted cancer pathways and make sure that we can use the right drugs or a combination to attack the right pathways in the body and make sure that none are missed. In addition, we've seen that tumor heterogeneity is a major problem because cancer can have these almost like subclonal populations where they can create so many different subgroups of the cancer cell that it's so hard to attack one certain cell. So just finding out how we can better identify those cell types. And then again, as I said, the different cancer types and stages, we need to identify how best to treat each stage, as well as including how previous cancer treatments may affect immunotherapy. And that is really the major things that need to be focused on in order to make it more predictable. And then the next thing is the need for more distinct clinical trials. So as I said, there are currently a lot of trials going on with many different companies. However, the major problem with the current clinical trials is that traditional clinical trial design does not detect the important endpoints that immunotherapy needs to be detected. So we see that with the trials, there is a very low prevalence of some of these very specific biomarkers because a lot of clinical trials require these very large trials in the third phases. It's hard for specific cancers to be tested because if you don't have a big enough population with that specific cancer cell type, it just takes so much longer to get recruitment, and it will take more time to start a study, and then the cost is greater, so it makes it very difficult to identify certain cancer types. So really in the future, optimizing these biomarkers in pre-screening methods to make sure that the person you are including in your trial will best be affected by the medication. And then again, just changing those traditional clinical trial designs to include smaller patient cohorts, which is necessary for these very, very specific cancer types. And then the next thing, again, is cost. And I think I touched on this a little bit with the clinical trials, but in addition to the actual trial, the drugs are very, very expensive. So a lot of healthcare institutions are burdened by the cost and are unable really to provide as much as they need to patients, have availability of resources. So that's a major issue for a lot of treatment facilities, because they don't have the money to support these trials, as well as providing the drugs. And then the next major issue is resistance to drugs. So cancer, again, is very, very smart and is able to change and pretty much hide from treatments. So really a major problem now is identifying which tumors may be resistant from those subclonal populations, and then again develop those combination pathways to prevent that resistance, to make sure that every single pathway is being met and attacked. And a major change in that will be biopsies to identify and target mutations that are causing relapse. However, the problem that we've seen is biopsies are expensive, and since they are surgery, it's painful and it takes time to heal. So we've seen these liquid biopsies that they are able to do without opening, surgically opening, will cause such a difference, because they'll be able to check biopsies before and after treatment and many times in between to ensure that things have not changed to a point where the drug will no longer work. And again, I think reducing time and cost is the main issue. And so using those liquid biopsies to monitor resistance can help to personalize treatment and then make that time and cost go down. And then lastly, the logistical issues, and I feel like we have touched on this, just challenges being that hospitals need specialized facilities, trained personnel, and that's more time and cost, which is just a burden to institutions that may not be able to afford that. In addition to healthcare institutions facing different challenges, patients also face many challenges when trying to get immunotherapy. So first is the high costs per patient really limit access, because unless you're in a clinical trial, the costs of these drugs currently are pretty insane, especially if you do not have insurance. It's very expensive for many patients, and most cannot get it unless they have insurance, which, again, we have seen in general. There's a lot of inequality within healthcare that causes people to not be able to get insurance. So there's a lot of issues with people trying to get the drugs in order to obviously help them with their cancer. But then the problem is, as I said, the previous cancer treatments at the bottom, a lot of people who cannot pay for that immunotherapy or got cancer when it wasn't available, who have gotten that radiation, chemotherapy, or surgery, are now at a disadvantage because your body has already attacked in a different way from previous treatments. So with chemotherapy or anything like that, they have targeted these pathways already, and because your immune system is already compromised because of those previous treatments, the results are not as good. So it's more difficult for the immunotherapy to restore those anti-tumor immune functions. So the best results are when immunotherapies are used first. However, again, with timing, if it wasn't available, or cost, many people have to use traditional treatments, which make immunotherapy maybe not an option for them in the later. And then the next thing, again, is the potential for inefficacy, because for patients who decide to use immunotherapy, they are putting their time and money and trust into it, and if it does not work, the disease could have progressed, or they're out of money or time, and that can be a big danger to patients. But again, if it's the only option, it's better than nothing. But healthcare providers can't ensure that it's going to work unless we have made all the steps that we discussed earlier. And then the next thing is that underrepresentation of minorities in clinical trials, which continues to talk about that inequality in healthcare, like I mentioned with the insurance. It's similar with clinical trials, since it is free and a great opportunity for people to get this immunotherapy. It's a problem that minorities are represented in clinical trials across the world in every trial, which just limits their ability to access treatment. And just to give a bit of a summary, since I have been talking about the cost for a bit, just to show, so these are just a couple. I think I listed out 5 different drugs that are currently FDA approved on the market from various different companies, and this shows the cost. So like you can see with that first one, the Keytruda, 4 milliliters costs almost $6,000 and lasts about a year. So every year that a patient will need the treatment without insurance, it will cost them about $6,000, which many people just don't have lying around. And so even if it's the perfect drug for them and can potentially save their life, they might not be able to access it. So insurance needs to be incorporated better with immunotherapies, and I know it's difficult with insurance when things are newer and making sure they're approved and whatnot, but it's just a bit absurd to assume that someone could pay $6,000 outside of their normal necessities for treatment. Another barrier for patients receiving immunotherapy are the various side effects we've seen with these drugs, and the common side effects are similar to really any medication that's new or affecting your immune system. So you see GI issues, some constipation, nausea, diarrhea, potentially flu-like symptoms, some respiratory problems, and endocrine disorders. And then on the severe side, so because immunotherapy can unleash these immune reactions that attack your cancer cells, there's also the potential that they could attack some normal cells, and patients can develop severe reactions that affect different processes in your body. So inflammation is a very common one, since you're really causing so many immune reactions. Inflammation is common, of course, but if it gets out of hand, it can cause heart inflammation, lung inflammation, and liver inflammation, which can be a major complication. And we also see neurological complications, which are very rare, but we have seen meningitis, encephalitis occur. And then lastly, the autoimmune responses. Because your body is utilizing so much of your immune system, the potential for it to be attacking itself is there. So that would be something like a diabetes or arthritis, where your body is attacking itself instead of those cancer cells. So, but this is only to highlight that there are side effects, unlike any other treatment, but this could definitely be something if someone has a pre-existing condition or maybe a family history, that they would be uncomfortable getting this medication because of the potential side effects. Overall, I think there are so many more benefits to immunotherapy than there are side effects and barriers. However, to overcome these barriers, we need to ensure that healthcare providers are focusing on what really needs to be addressed, including those clinical trial designs, the cost for patients as well as healthcare institutions, treatment resistance. So there are many factors that need to be addressed, but I believe that the future of immunotherapy is great. I think if we have all of that time and money, we really can develop cancer treatments with immunotherapy for every kind of cancer. It's just simply the fact that there are so many variations that it will take time to do trials for each one, ensure that the safety is there, get FDA approved, and then again, make sure that the costs are appropriate for patients, and then all of those other inequality aspects and resistance aspects. Once those have been addressed, I think immunotherapy really is the future of cancer treatment. That potential for lifelong remission is just so amazing, because it's, you get it and then your immune system is able to fight for you in the future, and I think that is incredible. As we've seen with vaccines, it really, really does work. it's just overcoming that time and cost and availability for patients that needs to be addressed before it can be widely used.